This is Stuart Gilman, and it's a privilege for us to be here. We are appreciative of everybody's time to come join us. Although Kathy and I are presenters, a third colleague of ours, Judith Bowen, who is the physician consultant to the Centers of Excellence in Primary Care Education, collaborated in authorship of the presentation. Dr. Bowen is a professor at Oregon Health and Science University in schools of both medicine and nursing. And we want to just mention that although we are here in our official capacity with the Veterans Health Administration, any opinions we express will be those of ours personally. I certainly want to also acknowledge before we get much farther that the work that although the three of us have developed this presentation from our point of view at the coordinating center of the project, that the work we're describing being done represents the effort of a great many people at the sites of the project, and you'll be hearing more about that later. What we are going to be doing with our remaining time today is first define some terms like academic pact or academic PCMH. We've found a little typo in our slide here. We'll then go on to describe the Centers of Excellence in Primary Care Education and what the work has been that these centers have accomplished and are still working on. We're going to talk about how the Veterans Health Administration is attempting to leverage what we've learned from this effort to a strategic approach to implementing more broadly the academic pact, and we'll be describing some of our successes, challenges, and lessons learned. So to get on with the content, the definition of academic pact, and it's basically the same thing as an academic PCMH, except that PACT is VA's implementation of PCMH. First, it might be helpful for those who are not in the Department of Veterans Affairs or familiar with the VA to recognize that in addition to being a very large integrated healthcare system, that the VA has congressionally required mission to educate to benefit VA and the nation, and that we represent the largest health professions education enterprise in the United States. We have affiliations with 126 of the 141 allopathic medical schools, 15 of the 26 osteopathic medical schools. We have affiliations with over 1,800 colleges, universities for over 40 other health professions. And the aggregate effort is that we have close to 120,000 health profession trainees come through VA facilities each year. And the impact on that is that we really have to integrate our trainee activity with our clinical organization because our education mission has such a profound influence on our clinical mission. Now, I mentioned earlier that VA calls our patient-centered medical home implementation PACT. That stands for the Patient-Aligned Care Team. And it has components that I think would be very familiar to folks familiar with the patient-centered medical home. The VA's PACT is implemented at every point of care for primary care throughout the VA. And this was started a couple of years ago. The pillars of VA's PACT are access, care management and coordination, and practice redesign. And these are built on the foundations of concepts like patient-centeredness, systems redesign and quality improvement, and adequate resources. Now, one difference between the general approach to patient-centered medical home and the specific implementation of VA's patient-aligned care team, is that the VA did not define the care teams as having to be physician-led, which is a definition in some PCMH settings. And this was an important point for us as we wanted to develop our educational environment within VA's PACT system. Now, I've described the general PACT, but the academic PACT then takes place in the context of a clinical PACT, and we're defining an academic PACT as a primary care clinical practice that includes educating health profession trainees as an integral component of its mission, that the trainees have authentic roles in delivering care. And authentic here is a term that we're pulling from workplace learning literature as a term of art, meaning what they're doing is real and is developing them to the real work that they would do when they have concluded their education. And the third point, that's a very important point in how we're approaching academic PACT, is that we believe that all members of the academic PACT have a role in educating trainees, not just the people we've previously recognized as clinical faculty. We'll be saying a lot more about that. Now, you'll see a link at the bottom of this slide, which is number 10, slide 10, for those of you not following on the webinar. And that link will take you to a document that is called the Blueprint for Change that is a basis for what we'll be doing going forward. So we recommend that folks take a look at that at some point. And I think we've gotten through the definition. So let me ask Kathy to go on and talk about our next objective.
Thanks, Stuart. Hi, everyone. So I'd like now to describe the VA Centers of Excellence in Primary Care Education. So really, this is a gap closing measure, and we really wanted to break down the healthcare professional silos with this demonstration project. So our overall goals are to transform primary care education. We want to prepare our trainees for team-based, patient-centered care for future practice. The focus of the learning environment is that it's interprofessional, and that's just not for the trainees, that's for faculty, all staff involved, the PACT team, the PACT team led. It's all inclusive that we work in an interprofessional environment. And then we need to shift our curricular models from classroom to workplace, and I'll be talking a little bit more of the shift of the pedagogy that we have seen at our centers of excellence. And then certainly we want to sustain these changes that have been made at our 5 centers of excellence and export them to other VA facilities and certainly beyond the VA. So I'll give you some background here. So in 2010, an RFP was released, and then to apply to become a Centers of Excellence, and 22 VA facilities, along with their academic affiliates, submitted full proposals. 5 centers were selected, competitively selected, and also a coordinating center was stood up. And our years of funding are 2011 through the end of our fiscal year 2015. The core requirements were that each site would have a physician and a nurse co-director and be allocated 50% protected time for the leadership and development of the center, that there would be joint sponsorship and engagement with the academic affiliates, and the primary focus was on the physician residents and nurse practitioner trainee. Certainly other healthcare professionals, trainees were welcome, but this was our main focus. Also that the trainees needed to be integrated into that PACT interprofessional team. Their resources, and the majority of the resources are for operations, and that really is for salary support. And then above and beyond that, operations or salary support, the trainee receives a stipend. That certainly is very commonplace for the physician trainees, but for our nurse practitioner trainees, that was something new and innovative, is that they got the trainee stipend. So let me introduce you to our 5 VA Centers of Excellence along with their academic affiliates, and we'll just go in alphabetical order. First is our Boise VA Medical Center. Scott Smith and Melanie Nash, the co-directors there, along with their academic affiliates, the University of Washington School of Medicine and Gonzaga University School of Medicine, along with some others. Next is our VA Connecticut healthcare system, located in West Haven, Connecticut. Our co-directors there are Rebecca Brianza and Susan Sabatka. They have several academic affiliates, Yale and the University of Connecticut Schools of Medicine, Fairfield University, Yale University, and Quinnipiac Schools of Nursing. Next is our Lewis Stokes Cleveland VA Medical Center. Mimi Singh and Mary Delancey are the co-directors. Their academic affiliates are Case Western Reserve Schools of Medicine and Nursing, the Cleveland Clinic Foundation, and Ursuline College School of Nursing. Next is our VA Puget Sound healthcare system located in Seattle, Washington. And their Joyce Whip and Tamika Brown are the co-directors, and their academic affiliates are the University of Washington, both the Schools of Medicine and Nursing. And finally is our San Francisco VA Medical Center. Co-directors there are Rebecca Shunk and Terry Keene. Their academic affiliates are the University of San Francisco, both these Schools of Medicine and Nursing. So how we implemented this is that there is certainly collaboration across our 5 sites with the central coordination at our coordinating center, as Stuart referred to earlier. Each center has been developed locally, so they have a very unique model at each site. And the program is expected to have an impact at 3 separate levels, and those are the point of care learning, also referred to as the microsystem, at the VA facility itself and the academic affiliate or the mesosystem, and then have the impact broadly on the VA nationally and also other external healthcare systems or the macro system. So Stuart, if you would now like to talk about our the model of redesign for education in practice.
Thanks, Kathy. Yeah, we'll just jump out to a little bit of theory to help folks understand what we were thinking about. So this diagram is provided to us from our Office of Academic Affiliations Chief Officer Malcolm Cox, and it can be found in an IOM report from last year from a conference called Interprofessional Education for Collaboration. And we refer to this as the eyeballs diagram. And what we'd like you to think about with this is that with the patient at the center, I think most people are familiar thinking about this interaction between the patient and the caring process, that blue oval beneath the patient. And that the caring process in a healthy system, and certainly in a modern PCMH, is undergoing constant practice redesign that modifies the process of caring and hopefully improves the interactions between the patient and the caring process. In the academic pact, what we're suggesting is that we simultaneously have a learning process going on that involves the patient clearly in that same place, right? Because that point of care is also the point of learning and teaching. And that learning process involving all the folks that we'll be talking about in a few minutes is supported by an educational redesign process. And what what we would ask you to think about with this project and the blueprint goals that VA is establishing is that we're trying to integrate this education redesign process to interrelate with VA's practice redesign process, because the patient is going through this clinical experience, and that's at the same time the educational and teaching experience for the trainees that are involved, and these have to be integrated at this point where the patient and the faculty and the learners and the staff are. So we're really trying to show you the strategy we've attempted to accomplish that. So now we can go on, I think, Kathy, and describe the trainees.
Sure. So we had our core trainees, as I mentioned earlier, were our physician residents and our nurse practitioner trainees. And we have those trainees at multiple levels. We have internal medicine and family medicine involved at the PGY 1, 2, 3 chief residents. Also, we have some psychiatry residents embedded into the sites. Our nurse practitioner trainees are also a wide variety. We have both pre-masters and pre-doctorate of nursing practice students. And then we have at all of our 5 sites now, we have a residency or fellowship at both at the postmasters and the post-DNP level. We also have long-standing in the VA, both postdoctorate of pharmacy and postdoctorate of psychology residency programs, and we also have some psychology interns engaged. And then you can see we have a wide variety of other healthcare professional trainees engaged at our sites, and they vary from site to site, but we have social work, nutrition, undergraduate nursing students, medical students, podiatry, and also physician assistant trainees. So let me talk now about our core educational domains, and this was in our RFP that the sites had to address these patient-centered care domains. So let me go through each one of these. We have shared decision-making, sustained relationships, interprofessional collaboration, and then performance improvement. So in the shared decision-making domain, care is aligned with the values, preferences, and cultural perspective of the patient, and then the curriculum focuses on the communication skills necessary to promote patients' self-efficacy. This domain also includes communication between the interprofessional team so that the patient is assured of having all the professions provide appropriate input to maximize the benefit of the care. In the sustained relationships domain, care is designed to promote the continuity of care, and the curricula focuses on longitudinal learning relationships. And these relationships are sustained through a matrix of the patient, the trainee, the faculty, and staff. And we'll talk a little bit more about that later, that it's a very complex and challenging aspect. In the interprofessional collaboration domain, care is team-based, efficient, and coordinated, and then the curricula focuses on developing trustful, collaborative relationships, again, among the all-inclusive team there, the trainees, the faculty, the staff. And then in the performance improvement domain, care is designed to optimize the health of populations, and then the curricula focuses on the methodologies of continuous improvement in redesigning care to achieve quality outcomes. And just a couple of examples, and we'll see that the pedagogy or the teaching strategies that are used are the formal instruction, workplace learning, and reflection. And really we see that didactic or the formal learning is most prominent instructional strategy that our sites are using we've seen our sites over now. We're in our third academic year, and that they're really changing the pedagogy and increasing workplace learning and reflection. So I'll give you some examples based on our four core domains and these various types of teaching strategies. Some sites have used the Team Steps, which is an evidence-based teamwork system to improve communication and teamwork skills among the various professions, and not just the trainees, but also the faculty. An example of workplace learning is that the faculty and staff and members of the PAC team are doing home visits. They're doing team huddles. They're participating in shared medical appointments. We also have home visits, telephone clinics, and secured messaging as a type of workplace learning. And then in the reflection category, all the sites are using a wide variety of debriefing sessions. One of our sites has developed a shadow a patient visit where the trainee actually goes with the patient through and experiences, what the patient experiences throughout their whole healthcare visit from check-in to, discharge. And then they actually write a narrative piece about that, so they have some self-reflection about the patient's experience, and then they share that with the interprofessional group. So now what we'd like to do is move on to our third objective, is to really talk about the VA's strategic approach to implementing this academic PAC. So we have the PAC that's been implemented nationally since 2010 in a very wide variety of the phase of implementation throughout a very complex healthcare system, 153 sites with about 900 points of care. So we're at various points in putting things together, and now we need to actualize how we transform PAC into an academic PAC, meaning that we have trainees in our settings. So what we really want to do is have the interprofessional faculty become engaged, that they need to develop the knowledge and skills and attitudes of interprofessionalism. Our faculty need to role model interprofessionalism. They need to have teamwork and communication that our trainees that become engaged in. And our faculty and our trainees need to understand the culture, the values, and the educational trajectory of each profession, because our professions are very different. For example, medicine is very different from nurse practitioner trainee. Nurse practitioner training is usually done on a part-time basis, where the student is working maybe full-time and going to school part-time, and they're taking concurrently the coursework while they're in the clinical setting, so much different than the traditional physician training of medical school and then graduating to the internship and residency. Another important aspect is that our interprofessional faculty are all engaged in becoming teachers, and that all members of the team, from the RN case manager to the LPN to the clerical staff, is that they all have meaningful roles, and that they also have meaningful roles not just in teaching but also assessing the learner's performance, and that we all must learn from each other and about each other and with each other, and that all teachers really must have some local support for development. So Stuart, would you like to now talk about workplace teaching?
Thanks. Yeah, this is just going to build on the last slide Kathy talked about, and I come to this from the point of view of internal medicine primary care, and I think many folks in my field often use interchangeably the term workplace teaching and workplace learning. And what I think our sites have helped us all understand better through their work these last few years is how many concepts we've had to unpack, if you will, or tease apart. And teaching and learning are very different in the workplace. And by that, we want to focus on this emphasis to shift from formal instruction to workplace learning. The third instructional element, as Kathy said earlier, is reflection. And what happens when we think about the workplace learning in a more comprehensive way is that we realize that, that what many have called the hidden curriculum, what is it that the trainees really see happening, is often different than what they're being told are ideal professional behaviors in the lectures. And we believe that an important step in providing better primary care education, certainly, which is one focus of this, and also better interprofessional education and improving interprofessional collaborative practice, is to achieve that role modeling, as Kathy was talking about earlier. And that requires, I think, that everybody working in this packed setting be deliberate and aware of their interactions. So this gets us back to that relationship between the learning environment and the caring environment, because what I think a corollary of these concepts is going to be that the trainees can really only learn to be ideal practitioners in an interprofessional primary care environment if they're working in a high-performing interprofessional primary care environment, right? Now, the issue of the teaching versus the learning, one of the places that a lot of people have appropriate concern about the interprofessional education at the point of care has to do with regulatory compliance. So supervision issues across professions, say, either for external compliance, such as with an ACGME resident review commission requirement, or internal institutional compliance with supervision requirements for patient safety issues or billing or related things. And we believe that a lot of those issues get resolved if we carefully distinguish between the roles of supervision, which is that very formal activity that fulfills the various compliance requirements, precepting, which is where the interprofessional supervision, one gets tripped up on these words anyway, but the precepting is interprofessional, and we have a number of our sites where we have faculty of different professions co-precepting trainees of various professions. So a physician resident may come to have precepting that includes a physician as well as a nurse practitioner or pharmacy or psychology faculty member working together, although there is one supervisor of record that is appropriate for the compliance needs. Now, instruction can happen from any other member of the team. So perhaps the RN care manager is not necessarily in a position to precept a physician resident, certainly cannot supervise the physician resident, but there's a lot of instruction in clinical processes and care that an RN case manager can provide to physician residents, nurse practitioners, students, and the other learners. And all members of the team can be useful in the faculty's roles for assessing the trainee's performance, because there's so much more to performance in a patient-centered primary care setting than simply the medical decision-making that may occur during the clinical encounter. Issues about interprofessional collaboration, assessment of the trainee's ability to engage in the other core domains like shared decision making with patients and with other staff, and those wider variety of expectations for the trainees. So with the interprofessional trainee engagement, we have definitely found that the trainees have been very excited to learn together, that they're prepared to, after they've participated in the activities that our sites have provided for them, that they're emerging prepared to work in these team-based practices, and that they're prepared to lead these teams in effective ways. But it's important to point out that although this is happening within the context of VA's clinical care settings, that the academic affiliates must be engaged and involved, because for many of these programs, the academic affiliates are responsible for the program accreditations and ultimately responsible for the curriculum and the assessment, and of course even the designation of faculty. So let me ask Kathy to take us along to discuss leadership issues.
Thanks, Stuart. So yes, when we developed this program, we wanted to make sure that the leadership was interprofessional. So in the RFP, it was written that there would be a physician and a nurse co-director. And so we want to make sure, too, that leadership is interprofessional and representative of all the trainees' professions present. So not only do we have the nurse practitioner and the physician, but we also have leaders from the other professions involved in decision making. We want all the leaders to be present and included for any clinical operational elements, along with any educational elements that come up, and we use the mantra, nothing about us without us. So going from, making decisions of scheduling to scholarship and publication, that would be our mantra. Also, in interprofessional leadership, we've seen the renegotiation of traditional roles and responsibilities that are really breaking down some of those long-standing silos and hierarchies. And what we really see then is the outcome of high-performing teams. So, Stuart, now would you like to talk about the scheduling complexity?
Sure, just briefly. There's a lot of barriers to achieving better primary care education and achieving that with the appropriate interprofessional focus. When many people talk about the barriers, one of the first things I know that my physician colleagues identify as a concern are accreditation limitations. And what's interesting is that we've found accreditation limitations from ACGME to be modest, but that one of the limitations had actually been in scheduling, and that's, I think, 3 of our 5 programs had originally achieved waiver status so that they could have long enough blocks of primary care engagement to fulfill the curriculum needs that we believed were necessary. So the physician models have really been emphasizing different strategies to immersion, meaning uninterrupted, undistracted engagement in primary care. And those blocks of immersion can range from 2 to 12 weeks, and then they repeat at different cycles. Each of our programs has somewhat different variations in how they're approaching that. The nurse practitioner trainee model has been different, and actually I think Kathy may be able to say more, but has been more disruptive in a way for the NP traditional training and the physician training has, because we have introduced scheduling strategies that allow the NP student trainees to have continuity with patients and the clinical environment for much longer periods of time than many programs traditionally allow. So we've been having our students spend 1.5 to 2 days a week in these environments for between 6 to as long as 36 months. And the sites have developed NP residency or fellowship. That's a full-time immersed engagement post NP certification for a year. The other comment about the scheduling issues, and to reflect on this, is to recognize a theme that you can also see through our presentation, which is to talk about the difference between the interprofessional and the intraprofessional, meaning since we've been trying to enhance the primary care education experience, there are things that are going to be uniquely necessary for the physician learners, for the NP learners, for the psychology learners, for the pharmacy learners, as issues within their profession. And then there's the interprofessional to figure out how we then sequence a core curriculum that allows learners of these different professions, each with their own professional education schedules, to be together appropriately for formal instruction and for the workplace learning, the elbow-to-elbow learning for the trainees together. We mentioned sustained relationships were a pillar for the PACT environment, and they're an important pillar in the academic PACT environment, but it logarithmically complicates because just as with shared decision-making, where in the clinical environment, many folks have the mantra for patient engagement to be not about us, without us, and Kathy described that we think that can have an analogy in the academic PACT across the professions involved. We also see that in sustained relationships, this becomes more complicated and has an analogy in the academic PACT. So in addition to having a sustained relationship for the trainee to the patient, we also recognize that it's important for the trainees to have relationships with their teamlet, the specific care team, with their mentors, preceptors, and clinical supervisors, and with other trainees. Now, we've recognized, and our sites have been really wrestling with how to maximize each of those relationships, and it's probably difficult. And I think one of the challenges for any site trying to tackle this will be to decide which of the sustained relationships are going to be the most important for them to maximize. Now, we've got other issues that are important that our sites have learned really make a difference, and one of them is space. When we go into the academic PACT, we now have a lot more people involved, both in direct care, but also in the learning and teaching process. So one needs to have more exam rooms available to have more trainees who spend longer with patients than do staff practitioners. You need space for the co-precepting, presuming that's a model you want, having a little, turning an exam room into the precepting room where there's one chair for the supervisor and one chair for the trainee doesn't work in these models. One needs to have more space, more seats for people to collaborate. And one also needs larger areas for formal instruction because you've now got larger groups that are coming together for lectures, presentations, workshops. And we're seeing in the photograph that was in that picture, we'll just pop back. You can see this is a very flexible room that's adjacent to the clinic area in our West Haven facility. The computers around the perimeter of that room are used for the clinical activity and work for the team, or they can come together, as you're seeing illustrated in the photo, to introduce the formal instruction that occurs within the flow of their day. We'll go on to talk about some of our successes, challenges, and lessons learned in the last few minutes that we have here. We will be extending the session a little bit to try to accommodate the delayed start that we had. So I think the successes that we can easily talk about is that the physician residency restructuring was very successful in adopting the ambulatory models, and that we found a number of the residency programs interested in changing their overall schedule to advance these goals. For instance, by increasing the immersion in the primary care and reducing the distractions when these physician residents are in the primary care rotation, the corollary is they're no longer being pulled out of their inpatient duties at unpredictable times, and they have better focus when they're on those activities. We've seen that the schools of nursing that collaborate with us have been willing to restructure to accommodate the NP student immersion that we've been talking about, and that the schools of nursing scheduling process, they often work on a different academic calendar than the School of Medicine counterparts, and they've been flexible in accommodating that. The NP fellowship and residency implementation has been very successful, and we've been very pleased that several of our sites have been retaining learners as new faculty members, and we've been seeing increasing interest from the local VA facilities in now stepping up to support some of the infrastructure of these programs. Kathy, we've got some challenges still, don't we?
Oh, we sure do, Stuart, yes. But I think, we've made great strides, and I think one of the really top ones is securing that protected time for precepting, teaching, supervision, mentorship, especially for the nurse practitioner faculty. I think that's been long-standing. The physician faculty have that protected time, but I think for all the professions that really we've made some great strides with. We've integrated all our trainees into teamless structures, but still having that very important longitudinal learning experience remains a challenge due to the nature of some of the program structures. So, we have, to collaborate with our academic affiliates. We still are challenged with implementing interprofessional co-precepting. Again, we've made great strides with that, and ideally would have faculty of all the professions available to precept a trainee of one or multiple professions at the same time. That is certainly costly and has an impact on everyone's time. We've made great stride in developing interprofessional curricula, but the staff of the faculty of all professions need protected time to develop the curricula, and it needs to be very deliberate that it is developed in an interprofessional manner. We do have some of our sites where our nurse practitioner and physician trainees share a panel of patients, and this is really important so that they share the patients, that they learn together, and they learn about the complementary nature of their roles that they each bring to the team and to patient care, and that they need to learn. And I think the sharing of a panel of patients really helps them identify which provider may be more appropriate for that patient's situation. And then we're also challenged with the evaluation of this is a small project in the scheme of things. Our sample size isn't great, and then dealing with the program evaluation versus is this really research. And then our lessons learned have been that our trainees are very enthusiastic about this, and that their enthusiasm has facilitated the recruitment of new learners into our sites. The trainees are very attracted to the interprofessional nature of our sites, and that it's team-based training models. The trainees value that they are able to learn about the experiences, roles, and skill sets of their other healthcare professional trainees, that they do have this longitudinal relationship, but it still remains a challenge, and that they do have responsibility for a panel of patients. And I think that's something new for our NP learners. And then, Stuart, do you want to finish us up here?
Yeah, thanks. Just a couple other points on what we've learned. One thing has been the increased workload or complexity of care for the clinical PACT teamlet. Now, we've talked about the members of the team, including the care manager, the medical assistant or LPN, and the administrative staff that are associated, having some new roles to be formally recognized as instructors and assessors, and having that kind of faculty engagement. But it also means that there's a lot more moving parts for each of those staff to keep track of as they try to maintain and sustain the relationships that exist, keeping track of which of the trainees needs to be aware of incoming test results or addressing patients' questions or those things, keeping track of that as schedules change and the trainees rotate and such. That really makes a much more complicated workload for the clinical staff for the same number of patients when they're in an academic setting. And I think we would come back to a final point to recognize that there's the within and across professions issue in some of the other elements. So, for instance, by being engaged in this immersive longitudinal experience where we believe we're providing these learners with superior primary care educational opportunities, well, that causes a problem for learners in other ways, right? These are complex systems. So as Kathy mentioned earlier, the NP trainees aren't always able to spend more time in primary care during the hours that we have available because they are attending their NP education as a separate issue to full-time or near full-time employment. And we've been hearing from the physician trainees that, as you would expect, by requiring more time in the primary care than their programs otherwise would, that reduces elective opportunities because their required time and other things doesn't diminish. And these are issues that we just need to recognize and attempt to manage as we go on. So that's pretty much what we've got for our formal presentation. We want to thank all of you who've been patient with us today and joining us for being with us. We want to thank Angela Merrifield and AIHC for providing us to represent our group's effort with you today. And we'd like to address any questions that time permits. Is Dr. Schmidt able to come back on and join us?
I'm testing to see if I can be heard.
There you are. Welcome back.
Thank you. And thank you both for such a wonderful presentation. I was able to hear all of the presentation, but was having trouble getting connected with my voice. So we are just about at time. I wanted to say that we will stay on the line to take some questions that have come in. But for those people who have to tune out at this point, I want to remind you of a couple of things before we go back to the questions. First, please complete an evaluation of your experience today by clicking the evaluation link at the top of the chat box. We welcome any feedback that will help us improve your experience going forward, and I suspect we will have some feedback about the beginning of the seminar today. Next, save the date for our upcoming webinar, Developing Interprofessional Education Collaboration Across Multiple Institutions, scheduled for March 4th. You can find out more and register for this webinar on the AIHC website. There will be an archived webinar recording of today's session available on the AIHC website in 1 week. And now I would like to go back to a couple of questions that have come in, which from my point of view are right at the heart of where we are in interprofessional education and questions that we're all struggling with. The first one has to do with what assessment tools have been used in the clinical setting that you found to be effective in assessing some of the core domains, especially shared decision-making and interprofessional collaboration. And I know we showed the tables, Kathy, that you developed, but we didn't have much time to talk about it, and I know there were some tools in that. So would you be willing to take up that question initially?
Sure. Thanks, Maddie. Yes. So for the shared decision-making domain, the sites have used a wide variety of tools, and a couple of them are the decision support analysis tool, and the other is the dyadic option scale. So those are, you would be able to find those in the literature. And also our sites use a lot of OSCEs so that they, have the trainees practice with standardized patients. And then also they do some videotaping for evaluation of things like motivational interviewing and how much they use shared decision-making aids, tools, techniques in their patient encounter. Also, our trainees evaluate both the shared decision-making and the interprofessional collaboration nature of their learning experience via our VA Learner Perception Survey. That's a long-standing VA tool that we've used, for many, many years to evaluate the trainees' experience.
Thank you very much. I'm going to move on to the next question, which has to do with whether the educational experiences you have been describing have led you to any indications that patient care is changing as a consequence of the team approach. And do you have any outcomes data that show the team-based care is having an impact on patient health?
I'll take this one if that's okay. So there's two, we've got to tease apart the issue of whether the PACT approach is providing superior results to VA's traditional approach, and that's a question about our general clinical practice. And then the other question then is, well, what about in the academic setting? How does having the academic PACT influence that? The answer to the first issue of what's the clinical impact, there have been some publications that have been presented. I don't have the citations handy now, but we could provide them later. Some things that were published last year, and I think something else, a good report was just published within the last few weeks that are starting to show some clear benefits to VA and our veteran patients from the approach to PACT. Now, the question about the trainee engagement is a much more complicated one for us because we haven't yet felt satisfied that we've been able to properly tease apart all of the issues involved in trying to assess that. So right now we're still in the developmental phase, trying to understand the impact of the academic PACT on patient experience and patient outcomes. So we don't have anything to share with you yet.
Thank you. Boy, the questions are pouring in now, and they're all really right on the money as far as we're concerned in terms of where the field is. And we're not going to have time to address them all. So at this point, before I take the next question, I want to make sure that people know that our presenters are willing to respond to questions that we don't have time to address during the webinar, and the answers to those questions will be posted on the AIHC website. So to give you a sense of the range of those questions, and then I'm going to ask you to field one more, there are questions about whether any of these sites that you've mentioned, the 5 sites, have medical school involvement. There's a question about what your program evaluation looks like. There is a question about where people can go for information for implementing change in the medical school curricula, and a very important question about how patients are responding to the new model and how you are including patient perspectives. And there's also a question about whether there's one ultimate decision maker in this team-based delivery or decisions made by group consensus. So let's go back to a quick one, which is, do any of these sites have medical school involvement?
Yes, they all do at the leadership and faculty levels, because all of the faculty for the physician trainees are identified through the academic affiliates, and we've mentioned those on one of the early slides. Not all of the programs have medical students having educational experiences in these settings yet, although several do.
Thank you. Thank you, Stuart. We'll take one final question before we officially sign off, and that's the question about how patients are responding to the team-based models, and how are you including patients' perspectives?
Kathy, do you feel?
Well, I think it's very early, and I think, Stuart, you kind of brought this up already, is that, we're early. I mean, and this is a small demonstration project. Also, we have some constraints about evaluating patients' input in the VA system and the nature of our system. Having a patient respond to, say, another survey has to get a very high level of approval. But we have a lot of anecdotes where we see that the patients know who their team is. I think that the sites have made, great, very innovative ways of introducing patients to, their team and who their learner is. So we've had really anecdotal examples. We're right now looking at how we can pull, and really the problem is matching the trainee to the patient to the outcome. And so that has been, somewhat difficult for us to do, but we are looking into that. And so we can see who the trainees' patient care load is, what their outcomes are, and then at some sites they'll be, with IRB approval, doing focus groups and patient surveys. But we don't have that data yet. We're really early on. And Stuart, I don't know if you'd want to say any more about that.
Well, just again, this is an issue of whether the patients are satisfied generally with VA's PACT implementation, and then what's the difference in the academic PACT. And that is the first question we're not attempting to answer. Other people in the VA are assessing VA's PACT implementation. We're trying to focus on this academic subset. And as Kathy mentioned, there are a lot of complexities for us to do it. So just a caution, many of you may be aware that VA has really an outstanding electronic health record and an excellent clinical data system. Even with that, we're finding it to be very challenging to figure out the right ways to try to pull information about patients and trainees and clinical outcomes out of those data systems. And as Kathy mentioned, we actually have more regulatory limitation in the federal government on surveying patients than do colleagues in other settings.
Well, thank you again for sharing your wisdom with us today, and thanks to all of those participants who've hung in there over time to participate in the question period. We do need to conclude the webinar now, and I want to again reassure you, those of you who have asked questions that have not been answered, that they will be addressed, and we encourage you to check out the answers on the AAE2 website. This concludes today's program, and you may now disconnect.